Minimum significance level of total ischemic burden. A. 1 hour in 24 hours. B. 2 hours in 24 hours. C. 3 hours in 24 hours. D. 5 hours in 24 hours. Correct answer A. 1 hour in 24 hours. Total ischemic burden is the sum total of all episodes of silent and manifest ischemic events usually detected on 24-hour Holter monitoring. An episode of ischemia is ST segment deviation on Holter which lasts at least 1 minute. Total ischemic burden of more than 1 hour during a day is significant. It may be noted that silent myocardial ischemia is as important as or even more important than manifest ischemia regarding prognosis. It could be dangerous as the individual is not warned by the pain so that he may continue to exert during the episode leading to catastrophic results. Many with silent myocardial infarctions may present later with heart failure due to absence of a diagnosis and early treatment. Current recommended anticoagulant for those with mechanical prosthetic valve. A. Dabigatran. B. Apixaban. C. Warfarin. D. None of the above. Correct answer C. Warfarin. Though the novel oral anticoagulants have a lower risk of intracranial bleeding than warfarin, they have not been approved for use in those with mechanical prosthetic valves. As of date, warfarin is still the recommendation of choice in those with mechanical prosthetic valves. This is because mechanical prosthetic valves are highly thrombogenic and needs warfarin, which acts at multiple levels on the coagulation cascade. First phase of ventricular fibrillation is known as A. Electrical phase, B. Hemodynamic phase, C. Metabolic phase, D. None of the above. Correct answer A. Electrical phase. Electrical phase, initial 4 minutes of VF. Hemodynamic phase, 4 minutes to 10 minutes after the onset of VF. Metabolic phase, beyond 10 minutes after the onset of VF. If emergency medical service arrives within 4 minutes, that is in the electrical phase, defibrillation first, as it is likely to be coarse VF and responds better to defibrillation. If after 4 minutes but before 10 minutes, cardiopulmonary resuscitation followed by defibrillation. If beyond 10 minutes, success of resuscitation is limited. Factors predicting stroke after CABG. A. Presence of intracerebral and extracerebral atherosclerotic disease. B. Demonstration of previous stroke by imaging. C. Atheromatous disease of the aorta. D. All of the above. Correct answer D. All of the above. Aortic plaques have a high chance of embolization while cannulating the aorta for cardiopulmonary bypass. Avoiding cardiopulmonary bypass with off-pump CABG may have an edge over conventional on-pump CABG in this situation. Previous history of stroke or transient ischemic attacks within the previous 6 months is an important risk factor for perioperative stroke. Though the chance for stroke is lesser with percutaneous coronary intervention at 30 days and 1 year, the rates of stroke rather catches up by 5 years, indicating a basic predisposition which manifests in due time. Which of the following is not a pointer to graft failure after CABG? A. Electrocardiographic signs of myocardial ischemia. B. Ventricular arrhythmias. C. 2 times elevation of CPK. D. New wall motion abnormalities noted on echocardiography. Correct answer C. 2 times elevation of CPK. 5 times elevation of CPK is the cutoff level for post-CABG myocardial infarction. In addition to this, hemodynamic instability could be a pointer of graft failure. Golub score and modified Golub score have been proposed for the risk stratification of A. Long QT syndrome, B. Short QT syndrome, C. Brugada syndrome, D. Early repolarization syndrome. Correct answer B. Short QT syndrome. The Golub scoring system allots points for shortening of QT interval, shortening of J point to T peak interval, clinical history, family history, and genotype. A score of 4 or more is considered to confer high probability, 3 points an intermediate probability, and 2 or less points a low probability. The scoring system has been modified by the same group in pediatric patients. Which of the following is a PCSK9 inhibitor? A. Rituximab, B. Alirocumab, C. Infliximab, D. Abciximab. Correct answer B. Alirocumab. Alirocumab and Evolocumab are PCSK9 inhibitors. PCSK9 inhibitors have been approved by US FDA in those whom hypercholesterolemia is not controlled with diet and maximally tolerated statin treatment, if they have clinically manifest atherosclerotic disease like stroke or myocardial infarction. Alirocumab can be given as a self-administered subcutaneous injection once in 2 weeks using a pre-filled pen. Alirocumab, when added to atorvastatin, reduced LDL cholesterol significantly better than that produced by adding ezetimibe or doubling the dose of statin. A recent meta-analysis has documented that PCSK9 inhibitors Evolocumab and Alirocumab are safe and well tolerated. They reduced LDL cholesterol levels by more than 50% and increased HDL cholesterol levels. LDL receptors in the liver are involved in removing LDL cholesterol from the blood. PCSK9 binds to LDL receptors in the liver, making them targets for lysosomal degradation. Inhibition of PCSK9 makes more LDL receptors available in liver for removing LDL cholesterol from the blood. New feature in 2015 revision of Jones criteria for acute rheumatic fever by American Heart Association. A. Inclusion of echocardiography for diagnosis of subclinical carditis. B. Inclusion of monoarthritis as a major criterion in moderate to high risk populations. C. Inclusion of polyarthralgia as a major criterion in moderate to high risk populations. D. All of the above. Correct answer D. All of the above. Salient feature of 2015 revision of Jones criteria by AHA is the inclusion of echocardiography for diagnosis of subclinical carditis. All the other points listed above have also been added in the specific context. Most common antithrombotic regimen for giant coronary artery aneurysms in Kawasaki disease. A. Low dose aspirin alone. B. Low dose aspirin plus warfarin. C. Low molecular weight heparin. D. Unfractionated heparin. Correct answer B. Low dose aspirin plus warfarin. Giant coronary aneurysms in Kawasaki disease have a high risk of thrombosis. Most commonly used treatment is low dose aspirin along with dose adjusted warfarin. Aneurysms with proximal and distal stenosis have a higher chance of thrombosis due to higher platelet activation by shear stress at the stenosis and eddy currents within the aneurysm. Presence of a chronic thrombus within the aneurysm is also prothrombogenic. Surgical management of aneurysm is by coronary artery bypass grafting. Excision and plication of aneurysms have not been successful options, sometimes leading to even mortality. Which of the following cancer has the highest relative risk of venous thromboembolism? A. Pancreatic cancer. B. Brain cancer. C. Multiple myeloma. D. Colonic cancer. Correct answer C. Multiple myeloma. Multiple myeloma has 46-fold risk of venous thromboembolism than healthy controls, while brain cancer has 20-fold and pancreatic cancer 16-fold relative risk. But by absolute numbers, most episodes occur with lung, colon, and prostate cancer. Chemotherapy confers 6-fold extra risk, though chemotherapy per se is not considered an indication for prophylactic anticoagulation in ambulatory patients. The exception being multiple myeloma chemotherapy based on thalidomide or lenalidomide. Commonest arrhythmia in pulmonary embolism: A. Atrial tachycardia, B. Ventricular tachycardia, C. Atrial fibrillation, D. Ventricular fibrillation. Correct answer C. Atrial fibrillation. Commonest ECG abnormality in acute pulmonary embolism is sinus tachycardia. The classical ECG finding in acute pulmonary embolism is S1Q3T3 pattern, though it may not be seen in many cases. Advantage of loop diuretics: A. Greater diuresis for the same degree of natriuresis. B. Useful even in the presence of renal impairment. C. Escalation to high doses feasible. D. All of the above. Correct answer D. All of the above. Their dose-response relationship is linear and steep. Coronary artery aneurysm in Kawasaki disease is most common at A. Proximal left anterior descending coronary artery, B. Distal right coronary artery, C. Left main coronary artery, D. Left circumflex coronary artery. Correct answer A. Proximal left anterior descending coronary artery. Coronary aneurysms in Kawasaki disease are most likely to occur in proximal left anterior descending coronary artery or proximal right coronary artery. Next common sites would be left main coronary artery and left circumflex coronary artery. Less common than these locations would be distal right coronary artery and the junction between right coronary artery and posterior descending coronary artery. While proximal coronary imaging is relatively easy in a child, imaging the distal coronary territory by echocardiography can be challenging and requires special angulations and meticulous observation. The measured coronary diameter should be compared with the mean values for the particular body surface area. More than or equal to 2.5 standard deviations for the given body surface area. Set score 2.5 or more is taken as significant coronary artery dilatation in Kawasaki disease. Measurement of left anterior descending coronary artery is given more importance than left main coronary artery because of higher chance of anatomical variation in size of left main coronary artery. Smoking reduces life expectancy in females by about A. 5 years, B. 10 years, C. 15 years, D. 20 years. Correct answer C. 15 years. Smoking reduces life expectancy in males by about 13.2 years and about 14.5 years in females compared to non-smokers. Dyslipidemia in metabolic syndrome is characterized by A. High triglyceride and low high-density cholesterol, B. High density cholesterol and low triglyceride, C. Low triglyceride and high density cholesterol, D. None of the above. Correct answer A. High triglyceride and low high density cholesterol. In addition, it is associated with a high fasting blood glucose level as well. Hypertension and abdominal obesity are the important components of metabolic syndrome. Principal route of elimination of unfractionated heparin: A. Renal, B. Hepatic, C. Reticuloendothelial system, D. None of the above. Correct answer C. Reticuloendothelial system. Unfractionated heparin, being a large molecule, is eliminated mainly by the reticuloendothelial system like abciximab. Renal excretion plays only a minor role in the elimination of unfractionated heparin from the body, and hence it can be used with better safety profile in the presence of renal dysfunction. In contrast, a significant amount of low molecular weight heparin, most commonly used being enoxaparin, is eliminated by renal excretion, about 40% by glomerular filtration, and hence dose has to be reduced in renal insufficiency. Which of the following does not indicate unfavorable outcome after CPR? A. Lactate levels below 2 millimoles per liter, B. Unwitnessed cardiac arrest, C. pH less than 7.2, D. Initial rhythm other than ventricular fibrillation. Correct answer A. Lactate levels below 2 millimoles per liter. Most frequent manifestation of acute coronary syndrome: A. ST elevation myocardial infarction, B. effort angina, C. non-ST segment elevation acute coronary syndrome, D. none of the above. Correct answer C. Non-ST segment elevation acute coronary syndrome. Non-ST segment elevation acute coronary syndrome can be further subdivided into non-ST segment elevation myocardial infarction and unstable angina, depending on whether biomarkers of myocardial necrosis are elevated or not. The prognosis is poorer if biomarkers are elevated, indicating need for early invasive strategy in management. Investigation of choice when the probability of coronary artery disease is more than 85%. A. Invasive coronary angiography, B. CT coronary angiography, C. Stress echo, D. Nuclear imaging. Correct answer A. Invasive coronary angiography. CT coronary angiography and functional imaging studies like stress echocardiography, nuclear imaging, stress MRI, or PET perfusion imaging are indicated only in those with intermediate probability of coronary artery disease. Intermediate probability is considered as probability between 15% and 85% in this case. In those with a low probability below 15%, CT coronary angiography and functional imaging studies are not indicated. Type 2 traumatic aortic injury is A. Intimal tear, B. Intramural hematoma, C. Pseudoaneurysm, D. Rupture. Correct answer B. Intramural hematoma. Type 1 traumatic aortic injury is intimal tear, Type 3 is pseudoaneurysm, and Type 4 is aortic rupture. Traumatic aortic injury is the second most common cause of death after brain injury in cases of blunt trauma. On-site mortality is around 80% for traumatic aortic injury. Most important cause of blunt traumatic aortic injury is sudden deceleration, as in a motor vehicle accident or a fall from a height. Torsion and shearing forces causes maximum injury at the relatively fixed portions of the aorta like aortic root, region of ligamentum arteriosum, and the diaphragm. Injuries may be noted at the aortic isthmus in 90% of cases. 48-hour mortality in unoperated acute type A aortic dissection: A. 25%, B. 50%, C. 75%, D. 90%. Correct answer B. 50%. Treatment of choice for acute Stanford type A aortic dissection is surgical, although endovascular treatment has been tried in certain cases. Even with surgery, perioperative mortality is around 25%. Neurological complications can occur in about a fifth of type A aortic dissections. Surgery for type A aortic dissection has been shown to reduce the 1-month mortality from 90% to about 30%. Predictors for postoperative mortality in Stanford type A aortic dissection: 1. Pericardial tamponade with shock, 2. Stroke and coma, 3. Malperfusion of coronaries or peripheral arteries. Example, mesenteric malperfusion with bowel ischemia. Anisosphygmia is an important feature to look for in suspected aortic dissection. What percentage of persons with aortic dissection have anisosphygmia? A. 30%, B. 50%, C. 70%, D. 90%. Correct answer A. 30%. Anisosphygmia or asymmetry between the peripheral pulses occurs in about 30% of those with Stanford type A aortic dissection. It is around 15% in those with type B aortic dissection. Though anisosphygmia is a typical finding of aortic dissection, It will not occur if the dissection flap does not involve the ostia of the aortic arch branch vessels or the iliacs. Most specific feature of pain in aortic dissection: A. Abruptness of onset, B. Location, C. Radiation to back, D. None of the above. Correct answer A. Abruptness of onset. Abruptness of onset of severe chest pain with or without radiation to back or pain in the back is the most typical feature of aortic dissection. Nature of pain may be tearing or sharp and different from other causes of chest pain. Chest pain occurs in 80%, while back pain occurs in 40%, and abdominal pain occurs in a quarter of patients. Chest pain occurs more often with Stanford type A dissection, while type B dissection causes pain in the back or abdomen. Blind spot for transesophageal echo for aortic imaging: A. Proximal ascending aorta, B. Distal ascending aorta, C. Proximal descending aorta, D. None of the above. Correct answer B. Distal ascending aorta. Distal ascending aorta just before the innominate artery is difficult to image with transesophageal echocardiography because of the intervening right bronchus and trachea. Rest of the thoracic aorta, including descending thoracic aorta from left subclavian to celiac trunk, can be imaged well by transesophageal echocardiography. Both short axis and long axis images are possible by multiplane TEE. True regarding D-dimer assay in venous thromboembolism: A. Positive D-dimer assay has a high positive predictive value. B. Negative D-dimer assay has a high negative predictive value. C. ELISA-derived assays have poor diagnostic sensitivity. D. None of the above. Correct answer B. Negative D-dimer assay has a high negative predictive value. A negative D-dimer is useful in excluding venous thromboembolism. Studies have shown that 3-month thromboembolic risk is less than 1% in those left untreated due to a negative test. But a positive D-dimer assay is not useful in diagnosis, as many conditions like bleeding, trauma, surgery, and cancer can cause elevated D-dimer values. ELISA-derived assays have a high diagnostic sensitivity of 95% or more. WHO maternal cardiovascular risk class for pregnancy in asymptomatic severe left ventricular outflow tract obstruction with hypertrophic cardiomyopathy: A. Class 1, B. Class 2, C. Class 3, D. Class 4. Correct answer C. Class 3. Class 3 indicates significantly increased risk of maternal mortality or severe morbidity. Class 3 risk is noted in those with asymptomatic severe LVOT obstruction or symptoms or arrhythmias despite optimal medical treatment or with moderate left ventricular systolic dysfunction. Class 1 is no detectable risk of maternal mortality and no or mild risk of morbidity. This class does not apply to HCM. Most women with HCM have a class 2 risk with small increased risk of maternal mortality or moderate increase in risk of morbidity. This group can include mild to moderate LVOT obstruction, asymptomatic with or without medications, well-controlled arrhythmia, and normal or mildly impaired left ventricular systolic function. Class 4 has extremely high risk of maternal mortality or severe morbidity, and pregnancy is contraindicated. They have either severe left ventricular systolic dysfunction or severe symptomatic left ventricular outflow tract obstruction. Cardiovascular features of Kawasaki disease: A. Coronary aneurysms, B. Myocarditis, C. Aneurysms of medium-sized non-coronary arteries, D. All of the above. Correct answer D. All of the above. In addition to these, pericarditis and endocardial involvement in the form of valvular regurgitation can occur in Kawasaki disease. Congestive heart failure can occur in severe cases. Raynaud's phenomenon and peripheral gangrene can be noted in some cases. Kawasaki disease is also known as mucocutaneous lymph node syndrome, originally described from Japan, but now it is known to occur in many other geographic regions, and it has become commoner than rheumatic fever as a cause of cardiac involvement in children in the United States. Kawasaki disease is more likely to occur in children below the age of 5 years and is associated with fever lasting more than 5 days. Other important features are non-exudative bilateral conjunctivitis, lesions in lips and oral cavity, exanthematous rash, and lesions in extremities. Intravenous immunoglobulin given early in the course of illness is important in preventing progressive coronary artery involvement, which is an important cause of mortality in Kawasaki disease. Late cardiac complications in Kawasaki disease include thrombus formation in the coronary aneurysms with myocardial infarction and obstructive coronary lesions due to fibrosis. Thrombolysis in pulmonary embolism can be considered up to A. 6 hours of onset, B. 12 hours of onset, C. 24 hours of onset, D. 2 weeks of onset. Correct answer D. 2 weeks of onset. Though the best results for thrombolysis in pulmonary embolism has been within 48 hours of onset, it can be useful within 6 to 14 days of onset of symptoms. It may be noted that thrombolysis is not recommended in those without hypotension or shock. Intermediate high-risk individuals with right ventricular dysfunction and elevation of troponin should be closely monitored for any hemodynamic deterioration while being treated with anticoagulation alone. Which of the following is not a glycoprotein 2B3A receptor antagonist? A. Eptifibatide, B. Tirofiban, C. Apiximab, D. Apixaban. Correct answer D. Apixaban. Apixaban is an oral direct factor Xa inhibitor, while all the others are glycoprotein 2B3A receptor antagonists, which are given parenterally. Apixaban is used for prophylaxis against deep vein thrombosis after orthopedic surgery and for other antithrombotic applications. Glycoprotein 2B3A receptor antagonists are mostly used in the setting of percutaneous coronary interventions. Glycoprotein 2B3A receptor is the final common pathway in platelet activation. Which of the following risk factors for sudden cardiac death is more important in pediatric age group than in adults? A. Maximum left ventricular wall thickness of 30 mm or more, or Z score of 6 or more. B. Unexplained syncope. C. Non-sustained ventricular tachycardia. D. Family history of sudden cardiac death. Correct answer A. Maximum left ventricular wall thickness of 30 mm or more, or Z score of 6 or more. Z score is the number of standard deviations from the population mean. In adults, though left ventricular wall thickness is an important risk factor, the relative value is less compared to other risk factors. This is because in some studies, extreme hypertrophy of 35 or more millimeters have been associated with lower risk, though the very low numbers in that group may be a confounding factor. Which of the following is a direct thrombin inhibitor? A. Apixaban, B. Rivaroxaban, C. Dabigatran, D. Azenocumarol. Correct answer C. Dabigatran. Apixaban and Rivaroxaban are direct factor 10A inhibitors, while Azenocumarol is a vitamin K antagonist. First three are newer oral anticoagulants, while Azenocumarol has been in use for decades. Therapeutic effect of Azenocumarol can be monitored with prothrombin time, while those of the newer anticoagulants cannot be monitored using widely available tests. Most common sustained arrhythmia in hypertrophic cardiomyopathy: A. Ventricular tachycardia, B. Ventricular fibrillation, C. Atrial tachycardia, D. Atrial fibrillation. Correct answer D. Atrial fibrillation. Atrial fibrillation is also the most common sustained arrhythmia in general population. Onset of atrial fibrillation causes decompensation of cardiac status in HCM because the stiff ventricle is dependent on atrial transport function for diastolic filling.